Good afternoon, everyone. Raise your hand if you got a good night's sleep last night. You did? Good, good. How many people think sleep is important? Okay, very good. All right, just priming you up. So it's my pleasure to introduce Dr. Alberto Ramos, professor in clinical neurology, research director of the sleep medicine program at the University of Miami Miller School of Medicine. Alberto's been here for 15 years at the University of Miami. He was a resident for neurology and a fellow in sleep medicine, so he's the expert. Runs a sleep clinic where you can go and get your sleep monitored and see if you're normal or abnormal or something else. He specializes in sleep disorders and how they can affect cerebral vascular disease and neurocognitive aging. So it's nice relationships between all of these types of events that are associated with aging and also neurodegenerative diseases. He is associated with the Northern Manhattan Study and the Hispanic Community Health Study for Latinos. Currently leads a $13 million R01. I didn't know R01s were that big, but anyway, $13 million R01 on sleep and neurocognitive aging and Alzheimer's research, which investigates the roles of sleep and apnea and nocturnal blood pressure as risk factors for dementia in Hispanic and Latino adults. So welcome, Alberto. Thank you very much for speaking to us today. Look forward to it.
Thank you so much. And a lot of the work that I do is in population-based studies, so maybe it's a little bit different from your research background and research methodology, but hopefully my talk can not only help with maybe some research ideas you may have. This has applicability across many fields. See. Right, so these are my disclosures, but I don't think anything that is relevant. And as an outline, I'm going to first discuss what is sleep. What do we know about sleep and dementia? Then basically discuss how sleep in many of our studies is associated with different neurocognitive outcomes. The relationship between sleep and vascular brain injury, and maybe can sleep be a biomarker for dementia too? Can we actually sleep? Could be in your research a portfolio. Could be the exposure or the risk factor. Could be a biomarker, and it could potentially be the outcome. And then we'll show you some of the next steps or the things that we plan to do ahead. So as an introduction, I think we all know here that Alzheimer's disease and related dementias are on the rise. This has vast economic and health implications. We have a population of people that are aging very fast. Now, sleep apnea, to use one example of a sleep disorder, it's estimated that about 1 billion people worldwide may have sleep apnea. And I'm going to show you some data about the US population. And if you don't know, sleep apnea is this disorder where people stop breathing in their sleep because there's obstruction in the back part of the throat during sleep, and that's associated with snoring. And then in apnea, you hold your breathing and you try to overcome that obstruction during your sleep. And that leads to hypoxemia, reoxygenation, and increasing pathetic tone. And we'll discuss that a little bit more later. But now, if all these people are at risk, all these people may have sleep apnea, who are the people that are really at risk and may benefit from treatment? So it's really very hard just to treat everyone worldwide. Now, we know that, for example, sleep apnea increases the risk of stroke 3 to 4-fold. And it potentially increases the risk of Alzheimer's disease. And of course, all of this is important because sleep disorders are treatable. We can treat sleep disorders. We can modify them. We can all have a good night of sleep, potentially. And equally important is, I'm talking about the duration of sleep, and this will be a recurring theme. We'll see that there's a U-shaped association between sleep duration and different health outcomes. So those people that consistently report sleeping about 7 to 8 hours do better than those that sleep less than 6 hours, or those that tend to sleep more than 9 hours. Now, there's different meta-analyses and other studies that have shown that For example, disorders like sleep apnea could potentially increase by 20% the risk of having dementia, same as having chronic insomnia, about a 50% increase in dementia. Those that have sleep fragmentation, and we're just having a conversation about it, they can have a 70% increase of dementia, as well as those that have these, that lay in the extremes of this curve of sleep duration, those that tend to have very short sleep duration or those that tend to have very long sleep duration. And these are the two different pathways by which we think sleep disorders are associated with increased dementia risk. And these are not mutually exclusive, but nonetheless, just to conceptualize this, you probably have heard by now about the glymphatic system of the brain to actually take a lot of the lack of a better term, junk out of the brain during sleep. And this is some of the early work out of the University of Rochester on the left side, where you can see the movement of CSF out of the brain during wakefulness is the red tracer. They were able to put different tracers, and this is perivenular movement of the CSF out of the brain during wakefulness. And then during sleep, you can see the green tracer, and there's a lot of movement of CSF out of the brain during sleep. And with that, there is movement of beta amyloid, alpha-synuclein, and other of these proteins that aggregate during sleep. The other story is then the vascular brain injury story, that you have increased risk of stroke, and hypertension, cardiometabolic disorders causing vascular brain injury, and by that process then increasing the risk of having dementia long-term, untreated vascular brain injury. But a lot of the epidemiological studies or population-based studies that we have they do have multiple limitations. They tend to use self-reported data. Many of these studies actually measure the sleep disturbances maybe too close to the time that the people develop dementia. So we know that the processes that lead to someone to get demented or have cognitive decline starts decades before the symptoms occur. So there's the risk of reverse causation. And many of these studies measure sleep only in a single measure. And there are other things, for example, like as alluded to earlier, there might be health disparities, groups of individuals that are at higher risk or have excess burden of these diseases. Yeah. So because of that, a lot of our work has been done in the Hispanic Community Health Study, or the study of Latinos, and this is an ongoing observational study of Hispanic Latinos across the U.S. There are 4 sites, one of them being here in Miami, the University of Miami, and then we have Albert Einstein in the Bronx, the University of Illinois and Northwestern in Chicago, and UC San Diego and San Diego State in San Diego, California. And the idea is not only to measure sleep here, there are a host of different cardiovascular measures and behaviors and other things that the NIH started doing in 2008 with the idea to understand the health of this population and to understand other issues, for example, like the Hispanic paradox, which you may have heard of, where Hispanics may have this excess of cardiovascular risk factors, but then have decreased mortality. So this is paradox of why this is happening and how we can explain it. And this is just to show you a little bit of a study design and the timeline of the study, where starting 2008 through 2011, Dr. Neil Schneiderman spearheaded the study from here in Miami from its inception, and we've had a host of different studies that are part of it, both from the different visits and the different ancillary studies. And then this is just a visual representation of all of the data that have been collected over the years. The visits 3, as you can see here, were just completed earlier this year, but there's anything from validated questionnaires, neurocognitive testing repeated now 2 times, and we're obtaining a third time, and plus there's genetic testing and and blood pressure measurements among different things. This is a very there's a lot of wealth of data in this cohort that goes beyond what we have done with the sleep data. Now, our interest has been in sleep in general, and there are many different sleep components, but we have emphasized on sleep apnea because it's the sleep disorder that we understand the most. And one of the first descriptions for sleep apnea was done by Charles Dickens in the Pickwick Papers, where he described this character that has many of the symptoms of sleep apnea. He felt sleepy, he snored, and he was very obese, and he fell asleep while idle. So many of the classic symptoms of sleep apnea that we describe nowadays, and if you're a clinician, you may recognize the initial Pickwickian syndrome of obesity, hypoventilation. We know now that people with sleep apnea has a very heterogeneous presentation that we will discuss in a moment. And this is what we see in one of our sleep studies, for example. You have the airflow channel, and all of a sudden the airway obstructs and there's no airflow. And then the person starts to increase the thorax and abdominal channels, and they try to increase the effort and start to even have what is called paradoxical breathing. Eventually, they open their airway, but with that, there's deoxygenation and reoxygenation, and there's also an increased sympathetic response with the opening of the airway that causes increased heart rate and blood pressure. Now, a lot of the data for the Hispanic study at baseline that I mentioned earlier, on visit 1, we were able to obtain, similar to the sleep study results that you saw, we were able to obtain 14,000 home sleep apnea tests that you can see here using this monitor or this device. Plus, we did about 2,200 actigraph a year later on a subset of individuals that were a little bit younger, and the actigraph is this watch-like device. If you're not familiar with them, are these watch-like devices similar to an Apple Watch or something like that, or similar wearable, where you can actually monitor the sleep-wake cycles and their daytime activity. You can see here, each row is a day of the week, and all these deflections are movements throughout the day, and eventually the person then is able to fall asleep and wake up, and fall asleep and wake up, and we're able to see things like the timing of their sleep, their duration, their sleep fragmentation, among other sleep metrics. And one of the first things that we looked at was at the prevalence of sleep apnea. How common was sleep apnea in this population? And just to put things in perspective, in the early 90s, there was a cohort study that showed that sleep apnea was prevalent in about 4% of males and 2% of females. In this study, we saw that about that sleep apnea was as common in males, about 31% increased prevalence across the years, and up to 20% of females had sleep apnea, more so. And there was an increasing prevalence of sleep apnea across the years, as expected across decades. And it was extremely common in males and females that were 60 years and older. And that's compared to some of the older cohort studies that showed a relatively low prevalence of sleep apnea in the general population. And then we completed a few cross-sectional studies on neurocognitive function and sleep apnea. And sleep duration. You can see here, this is the severity of sleep apnea, and that these are different measures of cognition, both for learning, memory, and executive function. And in a relatively group of middle-aged adults, we saw that the worse that sleep apnea was, the worse that these people perform in their cognition. We also saw that people that have this inverted U-shape association with sleep duration, meaning that those people that slept 7 to 8 hours did better in their cognition compared to those that were short sleepers, and those that were long sleepers did worse. So there's so consistent with prior studies, we observed that again the extremes of sleep duration are the ones that perform worse in cognitive function. Afterwards, we did we were able to obtain cognitive testing 7 years afterwards, And we did see that those that were actually longer sleep duration, those that tend to sleep more than 9 hours, had a decline in their cognitive function after 7 years. So these are the people that perform worse and had a decline in both in learning, memory, and word fluency after 7 years. People with sleep apnea actually did about the same, but these longer sleepers were the ones that did worse. And it's unclear for us why is that the reason. Short sleep duration. A lot of people are sleep deprived. I mean, we all have to watch, I don't know, the Heat game or something like that at night, and so we tend to sleep deprive ourselves a lot, and it's easy to sleep deprive someone in a laboratory setting. Now, to get someone to sleep longer, quote unquote, in laboratory setting and reproduce what is happening is very difficult. So for us, it has been very, very hard to understand why someone that will consistently sleep long will tend to do worse in cognition. And again, this is for hypertension and for mortality and dementia, for example. Now, one of my mentees and who's finalizing her K application for a K08 was able to publish this manuscript on looking at those that have different phenotypes of sleep apnea, and she was able to observe that people that had the combination of long sleep and this is a busy slide, sorry about that had long sleep and sleep apnea together did worse on memory, independent or regardless of having either metabolic syndrome or obesity. So even after removing those big cardiometabolic risk factors, the sleep issues, being sleep apnea and long sleep duration together, showed a decline in memory after 7 years. We also, using the actigraphic data, Dr. Agudelo, who's here in the audience, was also able to observe that there's a decline after 7 years. There's a decline in cognition, both in learning, memory, and global cognition, using the actigraphy. So the longer it took someone to fall asleep, which is a common symptom of insomnia, where someone have difficulties falling asleep, the longer it took them to fall asleep, the worse they perform, and they have a decline in their cognition after 7 years. So with this, we've been able to characterize different sleep phenotypes and maybe different sleep patterns that could help us define who are the people that might be a higher risk for cognitive decline and maybe dementia in the future. So one of the hypothesis that we have of why sleep apnea and other sleep disorders may increase the risk of dementia is through a process of vascular brain injury. And this is based on data that here from 2 different meta-analyses, now old meta-analyses, showing that people with sleep apnea has more than a 2-fold risk of stroke, which is a common, which could be considered a risk factor for developing dementia. And similarly, people with this U-shaped, people in the extremes of this sleep duration curve has increased risk of stroke, meaning those that are short sleepers compared to 7 hours tend to have like almost a 20% increase in developing increased stroke risk, and those at the long sleep duration end of the curve tend to have even a higher risk. So we think that provided that a lot of, for example, Hispanics and even other minorities like African Americans tend to have a large burden of cardiometabolic disease, hypertension, diabetes, increased stroke risk, that through that mechanism or through those pathways, sleep apnea and other sleep disorders may contribute to their excess risk of developing dementia. And our most recent analyses have tried to obtain or analyze data from neuroimaging in our cohort, where we try to define, large infarcts, lacunar infarcts, smaller infarcts in the brain that you can see here, as well as what is called white matter hyperintensity volumes, which is considered like chronic vascular injury of the brain, and other things like intracerebral hemorrhages. And we think that all these processes, either microvascular disease, as well as congestive heart failure and large vessels, may lead to hypoperfusion. And through this process of vascular brain injury, increase the risk of dementia and cognitive decline in our population. So some of the most recent analysis that we have done using baseline data and then looking at neuroimaging data that was obtained 10 years later, we've seen that the cohort is a little bit older now, 64 years old, but still kind of middle-aged to older adults. We observed that those that were long sleeper or slept more than 9 hours had decreased brain volumes in the parietal and gray matter areas. And then we also saw that those who were actually younger did have also decreased brain volumes in other areas of the brain. And in the sensitivity analysis, looking at those people that have sleep apnea only, those that with sleep apnea and every increment in sleep duration demonstrated a decrease in, for example, total brain volume and hippocampal volume, which it's one of the initial areas that damaged in Alzheimer's disease and other dementias, plus increased white matter hyperintensities. Another recent paper that is about to be published now in December in Neurology, we observe only sleep apnea participants and how in about 2,000 participants across the cohort, and see how sleep apnea severity was associated with different brain volumes. And we saw that sleep apnea increases, the more severe it is, increases the risk or increases the amount of white matter hyperintensity volumes, meaning this chronic ischemic damage of the brain that we see increase of white matter hyperintensity as seen here. And we also observe, and this is a little bit of a paradoxical finding, that the worse the sleep apnea got, there's an increase in the hippocampal volumes, in the hippocampus of the brain, the hippocampi, which is opposite of what our hypothesis was. We're not sure what was the case. We think that maybe there's an increased edema, that maybe there's other increased neuroinflammation, other things that may explain the increase in brain volume in people with sleep apnea, at least in this early analysis. Now, what could be the mechanisms that explain the association between sleep and vascular brain injury? We know that sleep apnea is associated with multiple risk factors, and I mentioned earlier hypertension, obesity, and others. And maybe through the process of subclinical vascular brain injury, as we saw, white matter hyperintensity increases the risk of stroke and eventually of dementia. Maybe sleep issues have their own mechanism, but it has been very difficult to disentangle the effect of sleep from other risk factors or other issues that may cause a vascular brain injury, because they usually coexist together. And mechanistic studies have been very hard to do in this population. However, we think that specifically sleep apnea increases the risk of vascular brain injury and cardiovascular diseases in general through two mechanisms. One of them is increased sympathetic nerve activity, and you can see here there's an increase in sympathetic nerve activity during wakefulness, and this is some of the old studies from Brent Summers out of Mayo Clinic. And if you provide them with a treatment, positive airway pressure, then there's a decrease in the sympathetic nerve activity. Similarly, when you're having this, we'll look at this respiratory channel, there's what is considered an apnea, and with that, there's an increased sympathetic response, intermittent, that goes with the apnea itself, and with that, there's an increase in the blood pressure. And there's another peak of blood pressure. There's an increased sympathetic response during sleep, associated with the apneas that maps to increments in blood pressure and heart rhythm during sleep. And we think that by this process, sleep apnea contributes to increased cardiovascular disease. The other process is the hypoxemia and reoxygenation, where you can see here the oximeter, and you can have kind of very, 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 very severe levels of hypoxemia. And at least hypothetically, we think that causes an influx of free radicals that causes endothelial dysfunction, and by that process increase the a host of atherosclerosis and other processes that may increase the risk of vascular brain injury in people with sleep apnea. And this is a cumulative process. This is, doesn't happen through one night. This is decades of exposure to hypoxemia, reoxygenation, and increased sympathetic response. And some of the epidemiological studies have shown that, for example, sleep apnea lead to increase of hypertension, the most common risk factor for stroke. One of the most common things that also cause a dementia risk, or increases the risk of dementia. Similarly, there's this is a busy slide, but similarly, we observe in the Hispanic Community Health Study that people with sleep apnea and insomnia have, after 5 years, an increase in hypertension, a 50% increase of 54% increase in hypertension, and 37% of increase for those with insomnia and hypertension after 5 years. And those with diabetes, sleep apnea increases their risk by 33% of incident cases of both hypertension and diabetes. And we know all these vascular risk factors increases the risk of stroke, mortality, and we know they're contributors to dementia. So we think that, again, the treatment for sleep apnea, aside from the treatment of the established vascular risk factors, could be one of the tools that we have to either change trajectories or even prevent cognitive decline and dementia risk. Now, what do we know about the treatment specifically for sleep apnea and other sleep disorders, and any improvements in the risk of dementia or vascular brain injury? Well, the main treatment, if any of you are familiar with sleep apnea and its treatment, the main treatment is this sexy contraption called CPAP, positive airway pressure, which what it does is pushes air through your nose or mouth, and by doing that, splits the airway open. There's also these mandibular advancement devices done by dentists that for the treatment of sleep apnea, and they just push the jaw forward, and by doing that, open up the space in the back part of the throat. And there's surgical treatments, including one of the most recent ones is called the Inspire therapy. You may have seen it in TV ad or radio. Well, basically is a neuromodulation of the hypoglossal nerve, and by doing that, stimulates the nerve during sleep and maintains the airway open by pushing the jaw forward. I mean the tongue forward and maintaining the tone of other muscles in the upper airway. There's also other things like bariatric surgery, which weight loss we know it definitely improve sleep apnea, may be curative for some people. There's some data from some of the recent injections that have been shown also to improve sleep apnea. Some of the recent injections for obesity, and there might be a pill available maybe next year for the treatment of sleep apnea. So medication that someone could potentially take for the treatment of sleep apnea. And there's some other treatments for insomnia and some other circadian rhythm disorders. So even though we know that the treatment for sleep apnea is very good for snoring, for sleepiness, for sleep continuity, a lot of the treatment studies to see if there's a risk reduction of cardiovascular disease have been actually negative. So this is just studies showing that the treatment for sleep apnea was not different to usual care in the treatment of in the risk reduction of cardiovascular events and mortality in a very large randomized clinical trial. And there are many critiques of different studies, but this is not the only one. And we think that maybe the signal that we use to treat sleep apnea and diagnose people with sleep apnea is just too noisy. And there might be different, usually many of the sleep disorders tend to coexist or collide into different sleep apnea patients, and maybe we need to have multimodal treatment for them. Because of that, there's now an effort to also describe different subtypes of sleep apnea. Understanding that if 1 billion people could potentially have sleep apnea, we know that not all of them will be at risk of cardiovascular risk events or dementia and so forth. So these efforts are trying to create, personalize, and understand who really is the at-risk individual. And there are different ways that we're trying to do this. And one of them is doing late-in-class analysis, looking at different sleep subtypes. And consistently, there have been 3 different types of subtypes for sleep apnea. Daytime sleepiness has been about 42% of people. The minimally symptomatic, or people that don't have major complaints but do have sleep apnea, tend to be older patients. And then people that have disturbed sleep. So they have sleep apnea, but they present more with insomnia symptoms and fragmented sleep. And we did a similar analysis, in this case done by Kevin Gonzalez out of UCSD. And we were able to observe that we had the same 3 different subtypes of sleep apnea. Interestingly enough, those that were minimally symptomatic tend to speak the most or prefer to speak Spanish more than the other groups. They were the less acculturated group, meaning the group that were less in tune, I guess, with the current culture or where they lived. And we also observed that those that had the disturbed sleep had the increased percentage of females. So we think that not only we have these different presentations, but the people that we see in the sleep clinic, for the most part, the people that tend to be very sleepy, males, loud snoring, and that might be another group of people out there that tend to have sleep apnea with disturbed sleep, maybe more insomnia symptoms, and they tend to be females that wouldn't get sent to be seen as sleep specialist. Most likely they'll be treated with a medication to help them fall asleep, while maybe their sleep issue is not treated, which in this case will be sleep apnea. So this is some of the controversies that we have encountered in many of these treatment studies. We think that maybe not everyone that we treat for sleep apnea will benefit from the risk reduction, for the potential of having a risk reduction of their sleep apnea itself. So there's a question maybe that those people that are asymptomatic do not need treatment. More so if the sleep apnea is very mild. We don't know what is the unclear impact of CPAP itself or the treatment for sleep apnea in the secondary prevention of cardiovascular disease. Right now, we don't have any evidence that treatment of sleep apnea does that. And there's even some people that will consider that sleep apnea may itself have a protective effect in some individuals. So maybe there's the hypoxemia may cause a little bit of a ischemic preconditioning and may actually be protective to some individuals. And then the other thing that has been considered is that the markers that we use for sleep apnea itself are just too noisy or too raw, and maybe developing better markers like things like that are called like hypoxic burden or using pulse rate response, maybe better predictors, are very specific for cardiovascular risk, and something that we can then extrapolate, for example, to dementia risk. And in a paper that was just published, that was a large consortium of different investigators. This is some of the things that we came about in terms of what to do next in terms of sleep apnea treatment. In this specific for cardiovascular disease, but I think it's all important for brain health too, is that we're able to, again, develop better metrics, understand the different subtypes of sleep apnea, so we can then provide personalized therapy and then define who is the person that will better benefit from the treatment or potential interventions, and then do our clinical trials and treatment studies based on not only sleep apnea subtypes, understanding who is the at-risk person, but also do clinical studies that are specific to that sleep apnea subtype, with the hopes that we are able to understand who is the really at risk and who is the person that really benefits from the treatment, again, for risk reduction. Because of that, most recently there's a large clinical trial to try to understand if the treatment for sleep apnea reduces the risk of stroke. It's called the Sleep Smarts trial. I think now it's in its third year, and we are one of the sites. And that study is at least in our site, is run by Dr. Jose Romano. So hopefully we'll have some answers too. Also, not only if by any chance the treatment for sleep apnea also potentially reduces the risk of stroke and mortality in our stroke population. So to start summarizing, I wanted to say that, of course, we know that sleep apnea increases the increased risk of stroke, hypertension, and other cardiovascular risk factors. We think it may also impair cerebral hemodynamics, and maybe through those processes causes cognitive impairment and increases the dementia risk. More so in populations that have a high burden on cardiovascular disease and cardiometabolic diseases like Hispanic and Latinos, which is the ones that we have been, examining the most. Also of importance is that the American Heart Association now includes sleep duration as one of their metrics for proper cardiovascular and brain health. So about 10 years ago, Dr. Ralph Sacco, when he was our chairman for neurology, and he was the head of the American Heart Association, and at the time my mentor, he launched what is called Life Simple 7, so different behaviors to improve, again, brain health and cardiovascular health. And now 10 years later, this has been rebranded into Life Essential 8. So this means that that American Heart Association thinks that sleeping anywhere from 7 to 9 hours, less than 9 hours, 7 to 9 hours, is as important as smoking, having proper blood pressure, proper lipids, weight, physical activity, and proper diet. So it's as important as other vascular risk factors that we always have thought that they're extremely important for proper, again, cardiovascular health and brain health. Now, in our future directions, we have now the current R01 that we are now in our third year, where we try to understand how sleep apnea itself, meaning the hypoxemia, and also the blood pressure changes associated with sleep apnea, like the lack of dipping of blood pressure. This is the normal blood pressure across the day, where you should have a dipping of 10% to 20% of blood pressure dipping during the night, and how those two things, affect cardiovascular disease, vascular brain injury, and then eventually increase the dementia risk. And this is, again, important because we also give us the opportunity to remeasure not only sleep apnea, but some of these other vascular sleep disorders that we know contribute to both blood pressure changes during the day and sleep, but also contribute to coexist with sleep apnea. And because of that, then we hope to obtain 3,000 participants from the Hispanic study, where we will do a sleep apnea testing. And you can see here the device that we use, where the person uses this for one night, and we can measure oxygenation, breathing patterns with these belts, and also airflow. And then this is the ambulatory blood pressure monitoring, that they wear this the day before for 24 hours, and we're able to measure their mean blood pressure throughout 24 hours, aside from any non-dipping of blood pressure during sleep, or how different is their blood pressure during sleep. Now, changing a little bit of gears, we are also starting to do some work on hopefully seeing if sleep itself can be a biomarker for dementia risk. I don't want to give you an advice on trying to where to put your money on, but nonetheless, this article from the World Sleep Journal think that maybe deep sleep is the best defense against Alzheimer's disease. If you remember, a lot of the lymphatic movement out of the brain, or the CSF movement out of the brain, happens during sleep, and specifically during slow wave sleep or deep sleep. And some recent data from the Framingham
cohort show that after many years of follow-up, those that they were able to do 2 different sleep studies 4 years apart, and those that after 4 years their slow wave sleep was stable or increased had an increase in dementia risk, which was as expected with their age groups. But those that had a decrease in the amount of slow wave sleep had an increase in the dementia cases after 4 years. I mean, many years of follow-up, but 4 years apart in terms of their measurements. So they concluded that the decrease in slow wave sleep increases your dementia risk by 27%. Also making a target of intervention and also of knowing who might be the at-risk individual. Because of that, we have actually developed, with the help of Bryce McConnell out of the University of Colorado, and using this type of wearables device that measure your EEG, see that different components of slow wave sleep or the deep sleep, and see how the slow wave basically is able to coalesce with what's called the sleep spindle, which sleep spindle has been shown to help with memory consolidation along with the slow wave. And if there is a disconnect, as seen here, in both the position and the timing of the slow wave and the sleep spindle, that has been shown to maybe increase the risk of not increase the risk of dementia, but has worse cognitive function, decreased brain volumes. And in this particular study, we were able to observe that this disconnect was associated with increased amyloid beta amyloid and p-tau, with the two proteins that accumulate in Alzheimer's disease in a cohort of 205 adults. So this is very early. We don't have a digital biomarker for Alzheimer's disease, but our hope is that with time we're able to understand, using these type of devices, who may be the at-risk individual, and maybe following over time in terms of being able to use this as a digital biomarker of increased risk of dementia. And to summarize, this is what we think is happening. We have sleep apnea, we have other sleep disorders, and the chronic intermittent hypoxemia that causes increased inflammation, oxidative stress, and through vascular disease, as I mentioned before, increased stroke and so forth, risk and vascular brain injury increases neurodegeneration, dementia, and cognitive decline. Similarly, the decrease in slow wave, as I mentioned earlier, also may decrease the lymphatic and decrease the amount of lymphatics that come out of the brain, and with that, there's less clearance of beta amyloid, tau, and other proteins that then can lead to dementia. So these are the two pathways we think by which we think sleep disorders contribute to the dementia risk over time. But of course, this is point of intervention and very easy to do. I mean, not very easy to do, but relatively easier to do than some of the other alternatives that we have for the treatment of dementia. Yeah. Yeah.
The age of onset for sleep apnea affect the probability of forming later dementia?
Yeah, that's a great question, and that we don't have a good answer. So sleep apnea tends to be unnoticed for decades. It's not a definite event. You cannot say, I developed sleep apnea these days. It's really a gradual process. It's kind of insidious. So we think that yes, that the accumulation of the exposure of being exposed to sleep apnea for decades in some people, that definitely has to play a role. But we don't have a good way to know exactly when someone started with their sleep apnea. Yeah.
You start having it as a teenager or starting your past effects of early life exposure.
Yeah.
Might be different than they do with onset.
Yeah. And I think those are great questions. I think those are great questions that we can try to understand. Yeah, a timing of exposure and how long someone has been exposed to untreated sleep apnea. And of course, without guarantees, know that the treatment of sleep apnea will actually change trajectories. We don't even know that either
But that's a great question. Yeah, that's a great question that we don't have a good answer right now. Yeah, go ahead.
When you measure effects of length of sleep, do you ever normalize to the activity that you look at before the
Yeah. That's a great question. That's a great question. We are right now. If someone has very long sleep, they may have less physical activity during the day. Yeah. Busy days, exactly. So that's something that we are actually actively looking at. We have the actigraphy data can allow us to look at daytime physical activity. Plus, there are questionnaires on physical activity and other measures that were done earlier too with the physical activity that was used at the waist, like a pedometer kind of thing. And we're actually looking at the differences, in sleep duration, physical activity, and how that predicts cognition. Because I think that's a great point. There's some studies suggesting, again, this is suggesting that increased physical activity may be protective, independent if you're sleep deprived or not. However, maybe these people are at higher risk. The risk doesn't come from the sleep itself. Maybe it is. Maybe there's something intrinsic about sleep, but maybe it comes from lack of physical activity, among different things, for example. Correct, and that too, yes. There's another question here.
What's known about that mechanism that regulates the flow of sleepless
time? So that's the glymphatic system was relatively, was described recently. I mean, relatively recent, maybe, I don't know, less than 10 years for sure. Neargard, out of the University of Rochester, It's been observed mainly in rodent studies. We think that basically during sleep there's movement of CSF that happens perivenular, and there's basically blocking on the term now, but basically the cells themselves opens up during the intercellular spaces. They open up during sleep time, it's a good question. Cory plexus, it might be involved. I do have one of the. Sorry to put you on the spot.
Cardiovascular broadly.
Yeah.
The flow of CSF sort of depends on where in the brain the cardiovascular space is. So the lymphatic system in and of itself is all the cardiovascular spaces, like a river system, right? Returning water from the mountain to the ocean. Same idea. And so the supporting features of that are the brain might shrink during sleep, implying that there's a greater extracellular to intracellular space, right? The increased extracellular space of fluid is one of the processes by which these metabolites that you try to say today gets dissolved, absorbed into that area, and then through a passive flow. And literally, like the pulsations of the artery will cause the perivascular fluid to flow as well towards this destination.
Yeah. Now these are.
Not true.
Yeah. It is.
It's an idea.
And then the anatomy said the mice and the humans are completely different. All this other stuff.
Yeah, so some people are trying to use some neuroimaging techniques to try to reproduce this in humans, but there hasn't been they haven't been able to do it yet. Definitely, yeah. Question here. Thank you.
The one that comes to mind is does that mean that pharmacologically extending the sleeping is something that will counteract the cognitive decline? Is that identified?
Yeah, that's a good question. Actually, the data at the population level, at least, shows the contrary. That using medications like benzodiazepines, which are commonly used, or sleep medications, could actually worsen or cognition, and potentially increase the risk of dementia. This is mostly in older cohorts, so we don't have good track of how of people over time that use these medications chronically. So, but as of this point, I personally try to get people out of these medications, out of pharmacology, and try to use more behavioral interventions, for it. Yeah. I think there's a question here.
Have you looked at, like, in your cohort, have you looked at patients who had sleep dysfunction but no obstructive sleep apnea, and their likelihood to actually have vascular dysfunction?
Yeah. So we have it seems that people with insomnia also have a decline in memory only. No, the sleep apnea was and those with longer sleep duration are the ones that seem to decline the most across different cognitive measures. Those with insomnia, like chronic insomnia, had only memory decline. And we have other studies using the actigraph, looking at sleep fragmentation, sleep timing, and things like that. And for example, one of the studies that Dr. Agudelo did, this showed that increase in sleep onset latency, or how long it took you to fall asleep, also was associated with decrease or decline in cognition after 7 years. So if it takes you longer to fall asleep, which is a very common symptom for someone with insomnia, those people were the ones that did worse over time and decline over time. And this is independent of sleep apnea. Also, we controlled for the severity of sleep apnea in all those studies. Yeah. Yes, go ahead, please. Yes. So great question. Yeah. So the relation with sleep apnea with parasomnia, and parasomnia is this sleep disorder. People have this abnormal behavior during sleep, commonly like sleepwalking or acting out their dreams. And yes, people with sleep apnea can have more parasomnias. The sleep disruption that causes sleep apnea can trigger parasomnia in some people. Who or why is hard to tell, but usually in those cases, once the sleep apnea is treated, the parasomnia should subside. Yeah. It depends on the type of parasomnia, yes, but there are different treatment options for parasomnias that tend to be medicated pharmacological for the most part, yes. But there are different treatment options. If there's the most common parasomnia that we see in older adults is called REM behavior disorder, where the person acts out their dreams. And in those, we use either melatonin that can be bought over the counter, or in some cases, they will require clonazepam, for example. The REM behavior disorder, yes. And I was debating if included here or not, but we do have, let me do this quickly. We do have, just want to acknowledge my friends, but also we do have several studies with Dr. James Galvin. He's an expert on Lewy body dementia and other dementias, but Lewy body dementia is alpha, as you probably know, as an alpha-synucleopathy similar to Parkinson's disease. And we have 2 studies looking at REM behavior disorder as one of the subtypes of Lewy body that increases the risk of Lewy body dementia. Yeah. So in general, 10% 50% of people with REM behavior disorder, assuming that's idiopathic, not caused by sleep apnea, will develop after 10 years will develop one of these diseases, and up to 85% of them after 15 years. Yeah. Okay. Any other questions? One more.
It's like sleep dysfunction is common among different types of neurodegenerative diseases.
Yes.
So your leading hypothesis is that it's probably because of vascular dysfunction that's causing the dementia.
Right.
But in all the other diseases, there is often a disruption in the neuromodulator tone. Could that be one of the possibilities? And maybe the vascular dysfunction is more related to the obstructive sleep apnea?
Yeah, I think that's a fair question. Yeah, that might be the case. That might be the case. In many of our studies, we're trying to address 2 things differently. One of them is thinking of sleep apnea as a vascular risk factor,
that causes vascular brain injury. And we're doing this in middle-aged, for the most part, middle-aged individuals, because as I mentioned earlier, that we have the dementia here at the end of it, but the process starts decades earlier. So the idea is that we are able to identify how sleep apnea contributes to vascular brain injury in those middle-aged adults. So we can define points of intervention for anything else. But in terms of specific mechanisms, at times these population-based studies give us a lot of information, but at times the specific mechanisms might be very hard to define. Yeah. All right. Any other questions? No? Well, thanks for your time.